Hello, everyone who's on the call. Hello for those who are maybe watching it on YouTube later. Thank you very much for supporting us. Next slide, please. This is our team. Dr. Galandiak she should be joining shortly. Always very helpful to have her overall supervision. Next slide, please. This is our disclaimer. Fairly self-explanatory. Next slide, please. So today we are fortunate enough to be at the San Francisco Bay Area in Stanford. 3 fun facts about Stanford that I found is that the Chinese fortune cookie was invented in San Francisco. Who would have thought about that? The Golden Gate Bridge was apparently supposed to be black and gold. Again, surprising, although I guess it's called the Golden Gate Bridge. And the third thing was that jeans were invented in San Francisco by a young Levi Strauss during the gold rush. So those are my 3 fun facts. But now I'm going to ask Dr. Brooke Gerland, who is both our special guest and the organizer of the local faculty, where she's done a wonderful job, to introduce her city, her institution, and her faculty, please.
Thank you so much for having us. You know, you may have heard a little bit about the Bay Area, certainly Facebook, Google, that's the Apple complex, Tesla, and maybe even the Da Vinci robot system, and many other things have come out of the Silicon Valley. So it's an area that's a lot about innovation and an exciting area to work in. And so then you might have also, heading to the next slide, a little bit about the Redwoods, the Golden Gate Bridge that's red, and that's the 17-mile drive with the coast where Pebble Beach is. So definitely there's plenty that you might have seen about it, and it's really a beautiful area to live and work, and you pay for it. So there's some of that too. So we're happy to be here, and maybe we'll head to the next slide, and I'll talk to you about this is our hospital. So this is the Stanford New Hospital, and what's so unique about our where we work is that the university and the hospital are all on the same campus. They call it the farm, like it, you know, you're really head to head with people who are working in engineering and bioinformatics. I'm working with a number of undergrad students who are brilliant. And then the hospital is right in the same area. So many people bicycle around. That's our, and then over to the side where you see, this is the Pelvic Health Center. Now this is about 15-20 minutes away, probably less, but there's always a little bit of traffic. And this is where in Redwood City, which is a little bit closer to San Francisco, where our Pelvic Health Center is located. And it's pretty unique in that we're all located in one location. A lot of people always ask me, does a pelvic health center need to be, could it be virtual? Does everybody have to sit in one space? So in our specific unit, we all sit and we kind of rotate at different days where we see patients, and we feel very fortunate about that. Although, you know, the EMR kind of brings us together in other ways. All right, and so then today, any questions, Vlad? Are you good with that? A little bit about our city?
No, that's fantastic. Thank you.
Okay, all right.
I'm very jealous of the architecture, not only of the bridge, but the actual hospital.
Yeah, it's really lovely. I mean, there's been a move, like Cleveland Clinic certainly did a great job with updating all of their rooms, and that move towards making hospitals look like, you know, hotels, boutique hotels. But, you know, at Stanford, they also had to think a lot about having earthquakes. So everything had to be constructed, and this went on for years. Like, I'm not sure anybody really thought that this was going to happen. So I'm lucky to have seen it, for it to be in, and I'm very lucky that we've gone through that initial, you know, where everybody moved to the new hospital, because moving to a new location or that, all that, there's little glitches that happen in healthcare. So I'm happy that we're over that. And I'm happy we're over, well, almost over COVID. All right, so this is who we have with us today. I'm really fortunate that I work with a fantastic team, and I've got a number of them that are on. Dr. Gahagan, Dawes, and I've got two of our trainees who are fantastic who are going to work with us. And then also one of our special panelists is Dr. Layla Nashadian, who's gastroenterology. And it wouldn't be uncommon for my entire team, my FPMRS team, to join us. They happen to be traveling because we're really a unit that works together. But I'm going to kind of stress at the end about how tight we are, like the gastroenterology colorectal relationship and how that really adds also. All right. And
okay, so we're going to have a quick poll. As everyone can see on the call, the question is, of the following options, which factors influence your operative choice for index full thickness rectal prolapse repair the most? And we're going to discuss the poll later on. And so in the interest of time, whilst that's going on, let's start the first paper. Next slide, please. And so the first paper is titled, "Does the length of the prolapsed rectum impact outcomes of surgical repair?" It's from the Cleveland Clinic, and it's fantastic that Dr. Gerland is and Dr. Hall are both on the call as co-authors of this. And hopefully we'll have Emmeline, who is Emily Nugent, who is the first author, who I think will be on the call as well. So the presenters are Dr. Kimura and the staff surgeon who will be critiquing it later, and thanks very much for attending, is Dr. Gahagan. So please start.
Okay, firstly, I'd like to thank the opportunity of presenting this paper today at the DC&R Journal Club. You can go to the next slide, please. Currently, there are many surgical options to treat rectal prolapse, and the techniques are typically divided into abdominal and perineal. There's currently no consensus regarding which technique is better, and there are many factors that influence the choice of the technique, such as age, comorbidities, and risk of recurrence. So in the end, it's up to the surgeon to decide what is the most appropriate procedure, taking into consideration all those factors. As recurrence of prolapse is relatively high after surgical correction, occurring in between 10 to 20% of the cases, the more we know about the preoperative predictors of recurrence, the better we can decide which one is the best approach. With that in mind, a few studies have examined such predictors, proposing that age, multi-compartment prolapse, weak tissue, and failure of surgical technique can increase the risk of recurrence. However, no other study so far had looked into the length of the prolapse, which is pretty simple to assess as a predictor of recurrence. So the authors of the study aim to determine whether the length of the prolapse could be associated with increased risk of prolapse recurrence after surgery. And next slide, please. Thank you. So the authors conducted a single center study with patients retrieved from a prospectively collected database from 2010 to 2018. Inclusion criteria were adult patients with rectal prolapse who were suitable for and underwent surgical repair. And exclusion criteria were patients with internal prolapse or no documented follow-up. The primary endpoint was to evaluate whether length of the prolapse influenced the risk of prolapse recurrence, defined as full thickness prolapse of the rectal wall or asymptomatic mucosal prolapse after surgical correction. So data collected included both clinical and surgical characteristics, and prolapse length was recorded retrospectively only in patients who had full thickness prolapse. The authors fitted a multivariable regression model with backward selection and a stay rule of 0.05. Length of prolapse was treated in two ways, both as a continuous variable and also as a binary variable, classifying the length between less or more than 5 centimeters. Next. So in the 8-year period, 280 patients underwent surgery for prolapse. The mean age was 59. 92% of the patients were women, 40% were ASA 3 or 4. The mean prolapse length was 4.8, and 70% of the patients had a prolapse measuring less than 5 centimeters. The mean follow-up time was 22 months. And of the 280 patients, 73% had an abdominal approach, mostly ventral mesh rectopexy and mostly robotic. and 27% had a perineal approach, 59% Delorme, and 41% Altemeyer. Next, please. So recurrence occurred in 18% of the patients, and the median time to recurrence was 32 months. On univariate analysis, factors that were associated with recurrence were perineal approach, having a previous Delorme procedure, and having a prolapse of 5 centimeters or more. No association was found for any of the other measured covariates. Factors that were significantly associated with prolapse of 5 centimeters or more on univariate analysis were increased age, perineal procedure, Delorme procedure, open or laparoscopic approach instead of robotic, having a combined pelvic floor procedure, having previous hysterectomy, and having a previous sacrocolpal perineopexy. Next. On multivariate analysis, the only factors that remain significantly associated with increased risk of recurrence were having a previous Delorme and having a prolapse of 5 centimeters or more. In this association between prolapse length and recurrence persisted even when treating the length of the prolapse as a continuous variable, as the author showed very nicely in this graph. According to the multivariate analysis, each 1 centimeter increase in prolapse length increases the odds of recurrence by a factor of 2.2. Next. So the authors conclude that there is an increased risk of recurrence with increasing prolapse length, and therefore the length of the prolapse should be taken into consideration when planning surgical repair. They also conclude that an abdominal procedure should be offered for patients with prolapse of 5 centimeters or more when possible, since abdominal procedures have been associated with lower recurrence rates. Limitations of this study include the retrospective record of length of the prolapse. So it is possible that they could have missed the true length in patients who were not prompt to strain maximally at the time of examination. Another limitation of the study is heterogeneity of the population, with not only different clinical and surgical characteristics, but also with different durations of follow-up. And lastly, as this was not a randomized trial, surgeon preference may have introduced selection bias, especially for older patients with more comorbidities and longer prolapse, for whom a perineal approach was probably more likely to be offered. And that's it. We're open for the discussion.
Thank you very much. That's a wonderful summary. I might take this opportunity to ask Dr. John Gahagan to make some comments about this paper, please.
Sure, thanks very much. Yeah, I think this is a very interesting paper and something that I had not thought about prior to reviewing it, about the length of the prolapse impacting recurrence risk and repair. Certainly, I think my first impression of it is that it makes intuitive sense that a larger prolapse sort of connotes some more severe disease and may then therefore impact the recurrence rate. And clearly that was demonstrated here, that there's an association with the length of prolapse with the overall recurrence. I think, as Cynthia pointed out, part of the decision making can be difficult. What we see here in this paper is it showed that longer prolapse length is also associated with increasing age, and by some extrapolation, increasing comorbidity profile. And so, as Dr. Gerlin knows, in my practice, I struggle with, trying to figure out what the right operation is. And we tend, as was pointed out in the introduction here, to favor perineal procedures and trade off recurrence risk with a risk profile for patients that are older, which, as this study shows, may also have increasing prolapse rates. And so, I think the conclusions here of considering abdominal approach for those that may be older but are otherwise fit to have longer prolapse lengths, I think is very reasonable. I will say, I think one of the limitations that Cynthia pointed out that I also sort of noted was that I think that while the conclusion to offer abdominal versus perineal resection based on prolapse length, I think is reasonable. One of the sort of comparisons that I think I didn't see here was a direct comparison of prolapse length by procedure. So for example, looking at the rate of recurrence in less than 5 or more than 5 in just the perineal group or in just the abdominal group, I think there is some limitation in the conclusion, a little bit of bias in that there is an association between the prolapse length among those that there's a greater proportion that had a larger prolapse length in those that got a perineal approach versus those that got an abdominal approach. And so while I think the conclusion is supported, I think a little bit more evaluation of how that length affects a particular operation rather than just the overall length in our decision making.
Thank you. That's a very good, those are very interesting points. Now, I might put the first question to Emily Nugent, who was the first author. Always fantastic to have authors on. It's a very humbling experience to have people to attend this, particularly if they're halfway across the world and it's probably like 2 o'clock in the morning or something. Now, my question to you is, how did you decide on 5 centimeters? Because that's the dichotomy in this. And do you think that the prolapse symptoms are proportional to size? So do people with greater than 5 centimeters suffer more than people who have 2 centimeters?
Thank you very much for the invitation. Thank you, everybody. I suppose at the time when we picked kind of 5 centimeters as kind of the differentiation, it was based on the guidelines, the American guidelines, as to, you know, what was considered appropriate for a Delorme's or a perineal approach versus an abdominal approach. So that was kind of our rationale at the time. And then in relation to your question about symptoms, I suppose I probably would very much defer to Dr. Hull and Dr. Gerland, because their expertise in this area is so much greater than mine. But absolutely, I think, you know, the length of prolapse does reflect patient symptoms. As you could well imagine that, you know, it can often be quite uncomfortable if you have a greater length of prolapse and, for example, in terms of your mobility, and suddenly you have a difficulty with that. So yeah, that has certainly been my experience to date.
Thank you. Now, that's fantastic. Unless Dr. Gerland or Dr. Hull want to add anything, I might have the next question. And the next question is, perhaps to Dr. Gerland or her team, what are some of the tips when you evaluate patients in the office for full thickness prolapse? Because, as Cynthia mentioned, there is a limitation of, you know, measuring and having a shorter measurement if you base it on the office examination.
So I think what you asked me is, how do I handle this in the office when I'm thinking about a little bit about the decision making, perhaps, you know, like when I'm looking at somebody with severe versus not. I would say that each patient has their own unique experience, except once they have fecal incontinence, they have it. Once they have difficult evacuation, they have it. And if the prolapse is causing them pain, then it causes pain. And they can't differentiate what size that is that it occurs. I definitely think that when it's a much larger prolapse, that the status of the pelvic floor is worse because it is not supporting the rectum in the way that we want. So at least there's some, like the tone seems to go down and the whole pelvic floor is not as functional. So I am definitely noticing that. And I'm also thinking about what I will need to do to repair it, like my degree of dissection. My choice of abdominal versus perineal is really going to be more about the patient factors and this concept of frailty. Like, can they tolerate an abdominal operation or can they not? So if they can't, then I'm going to do a perineal operation, and then they're going to have to accept for their own safety a higher recurrence rate. If they can tolerate an abdominal operation, I'm going to choose that. And then in my own personal, if I see that they have a larger prolapse segment, then it's possible I might add a little bit more dissection. So I'm a big, I do a lot of ventral rectopexy, yet if you have a 6 or 7 centimeter prolapse, I'm not convinced that a piece of mesh on the front will be enough to hold in your very large segment of prolapse. And may opt to do some additional dissection. So, that's how I approach it. Maybe Tracy wants to comment and see if she has any other thoughts.
So I think you're right. In this day and age, I think that the majority of patients can undergo an abdominal procedure. I don't think age should be the limiting factor. I think frailty. And if I'm going to do nowadays, if I do a perineal procedure, almost always it's somebody that's so sick they can't even have general anesthesia. We do it under local. I know that not everybody has that thought process, but that's kind of how I look at it. With minimally invasive techniques and good anesthesia, the majority of patients can tolerate a minimally invasive repair. I think it's really important to. So I agree with Dr. Gerlin. Some patients that have a little prolapse have a huge amount of symptoms, and some patients where, it goes halfway down their thigh, they're like, oh, I've had this for 20 years, it doesn't bother me. So I think the patient, each one has their unique interpretation of it. So I think it's important to look at the whole pelvis. I think Dr. Gerlin would say the same thing. And if you need to work with your middle and anterior compartment comrades, I think that's important. But my first choice is always, I want the patient to prove to me they can't tolerate an abdominal approach when I'm evaluating them, if they have prolapse. And I'm still a believer of putting them on the commode and looking and giving them an enema if you have to. I won't operate on somebody else's evaluation of the prolapse. I want to see it myself. I think that's really important. I don't want a picture. I want to see it myself.
I'm good with pictures, just for the record.
How do you know that I'm not good with pictures? Because
lies in a picture. If they put their iPhone there, who lies?
We have had patients lie who were, yes. So I want to see it myself.
Perhaps the picture needs to have a tattoo which is personalized to the person. Anyway, thank you for those answers. That's great. My next question is related to preoperative investigation, both to the prolapse and to the frailty component. And so what do you do at the moment before you offer a patient a prolapse repair?
I can answer that if you like. So I happen to, I'm currently using a frailty index. I've played with a number of them. And the initial frailty index was my own sort of version because, I don't want to add any more time in clinic. So if you could get up from your chair and walk over, that was a get up and go. Like if you can come, you can get on the table, you can move around, you've already passed a certain test from my perspective. But right now I'm currently using the RAI, which is, a validated tool. So I'm doing that. So for all of these issues where we can't really compare between the two groups and, like I know because I was part of that, I was at the Cleveland Clinic operating and it is a heterogeneous group. So I've really started to use that frailty index as a way to help me determine, but some of it is, my own gestalt, like what are their cardiopulmonary, what are their other things? And I'm big on talking about this concept of shared decision-making. So yes, I will push towards an abdominal, but there's some people who don't want to take the operative time, like they don't want to be under anesthesia as long, and I can do a perineal procedure in a much shorter time period than I can do an abdominal. So again, I'll push towards an abdominal, but there are some other factors that it might also contribute.
Thank you. Now, Brooke, I'm going to direct all the questions at you, but you can decide to, pick on someone either in your faculty or whoever's on the call. My question is, for the patients that have a anterior and posterior prolapse repairs, is it the patient's presenting complaint, or is it part of the investigation and workup after they come with rectal prolapse that determines that?
I feel guilty about passing this off. So I will say that I do an exam and look for it. I check for symptoms, right? So you may have someone who clearly has symptoms and then they get sent for an evaluation. I feel a bulge, I have urinary incontinence, they get sent for an evaluation. They may not have any symptoms, but you might see it on exam, which means I'm always looking at the vagina in addition to the rectum. So if I see that on exam, then they get an evaluation. They might have imaging because I do an MR defecography, and the MR defecography, they may have no symptoms. I'm not really getting a lot on the exam, but the MR defecography shows prolapse. Then they also get an evaluation for that compartment. So that's kind of my pathway.
Thank you. And my last question for this paper is, in terms of, you've mentioned that you do additional dissection when there's long prolapse. Do you factor in the potential of prolapse recurrence in the first operation that you do? In that, certainly there's a school of thought in some surgeons, particularly if there's a psychiatric association with patients, that they might do a less invasive operation first, knowing that whatever they do, their recurrence is quite high. But at least they don't burn any bridges and they don't put mesh in, say. So does the risk of recurrence play into your initial operation?
So Aaron spent time in Minnesota. Maybe Dr. Jaws wants to just come in and see what he saw, because he certainly did a lot of pelvic floor. You know, and I don't mean to put you on the spot. Like, I'm happy to answer that also. You're asking, like, I'm always worried about recurrence, right? Like, that's our, you know, we don't want it to recur, but we know a certain percentage will.
Sure. I wouldn't say that I, would approach it much differently, other than being sure I can get to the principles I'm trying to achieve during the operation. So doing as low of a dissection as I can to be sure I'm getting all of the prolapsing rectum exposed, so that I can, especially when I'm doing a ventral, I'm putting the mesh as low as possible. I'm identifying my landmarks. I'm really, identifying the ligament, not the crappy tissue on top of the ligament, so that I'm really able to anchor it. So I think I just take an anatomic approach to be sure I do as good of a prolapse operation as I can at that moment, not necessarily saying this is going to be better or worse for a future prolapse repair.
Thank you. And perhaps, given that we've started talking about the technical aspects of the repair, it's time to move to the next paper. So the next paper is from the Oxford team in UK. It's titled "Impact of Suture Type on Erosion Rate After Laparoscopic Ventral Mesh Rectopexy Case Match Study." And the doctors presenting and discussing are Dr. Raja Singh and Dr. Dawes. So please start when you're ready.
Okay, thank you for the opportunity to participate in today's journal club. You can go to the next slide. So laparoscopic ventral mesh rectopexy is an increasingly popular option for rectal prolapse repair. There are favorable functional outcomes, particularly when compared to the posterior suture rectopexy, and the repair is robust when compared to operations like the perineal operations. The overall mesh complication rate reported in the literature is low, around 2%. But when complications do occur, they can be significant, with significant morbidity for the patient. Complications have been associated with polyester mesh versus polypropylene meshes, which are more commonly used, or biological meshes. And anecdotally, in some case series, there are reports that non-absorbable suture has been found at the site of the mesh erosion, and that has prompted some concern that the suture acts as the nidus for the erosion. The key question then of this paper was if mesh erosion and fistulation rates vary with the type of suture used, primarily if you compare non-absorbable suture with absorbable suture. We can go to the next slide, please. To answer this question, the authors did a retrospective analysis of a prospectively maintained single center registry of rectal prolapse repair operations. There were 3 operating surgeons who contributed cases here. And based on their report, they all switched from using non-absorbable suture to absorbable suture at the end of 2013. Otherwise, they reported having consistent technique throughout the study period, and they all used the same polypropylene mesh throughout. They did two comparisons, a simple cohort comparison of the non-absorbable suture group, which were cases from January 2010 to, I believe, December of 2013, and then to patients with absorbable suture who, their paper said January 2013, I wonder if it was meant to be January 2014 through September 2017. They then secondly did a propensity score match comparison of two cohorts, which were matched on age group, gender, and importantly, length of available follow-up, primarily because the non-absorbable suture group had a much longer follow-up time in their study. Their primary outcome was symptomatic mesh erosion or fistulation, and their secondary outcomes were operative time, intraoperative complications, and adhesive bowel obstruction. Next. Their primary results are shown here. Of their descriptive variables, it's notable that in their unmatched cohort comparison, there was a significantly longer operative time in their non-absorbable group. And that was true also when you looked in their propensity matched analysis, though it was no longer significant, perhaps because of the smaller sample size. Additionally, there was a longer follow-up time in the non-absorbable group, which appropriately in their matched analysis was adjusted to be a non-significant difference between the two groups. In their outcomes, they noted no erosion in their absorbable suture group and a significantly higher rate of mesh erosion in the non-absorbable group in both their matched and unmatched comparisons. And the mean time to mesh erosion was 38 months. Next. Their conclusions were that the suture type was indeed associated with mesh erosion rates, and this is consistent with both the anecdotal reports as well as reports in the literature from other types of pelvic organ prolapse repair. That said, there are several limitations of the study that are worth highlighting. Firstly, the mean follow-up time was markedly shorter in the absorbable suture group, even though the mean time of erosion that they observed for the events that happened were about 38 months. I think if their suture-driven erosion hypothesis is correct, then perhaps this is acceptable because the PDS suture would have dissolved at that time. However, if they are in fact wrong about that and erosion was independent of the suture type and just a function of the mesh alone, they may have missed observing the outcome in their absorbable group. Additionally, there was a marked difference in the operative time between the groups. And I wonder if this does reflect some unmeasured confounders, particularly in change of technique between the two time periods that they mentioned. They didn't report several patient characteristics that are known to be associated with mesh erosion, such as smoking. And things like smoking may have in fact changed over their study time period. And I would have liked it if they had been able to match on those characteristics in their matched analysis. A small point, but they didn't specifically mention if this was all patients within their registry who underwent a VMR during this time period, or if they had applied other selection criteria to their case populations. And then finally, and I think importantly, they didn't report on recurrence rates, patient outcomes, or patient satisfaction, which may represent the other side of the coin here, if, for example, higher recurrence rates are a trade-off with using absorbable suture. So with that, I think I'll turn things over to Dr. Dawes.
Thank you for that. That's a wonderful summary.
Thanks, Charlotte. A really good presentation of an interesting article. So I guess I kind of think of the article in two different groups. I'm probably a better methodologist than I am a prolapse surgeon. So there's, overall, I would say, the gestalt, as Brooke said of the article, or the content validity is there, right? If something is potentially a source for continued inflammation and creation of a fistula, the longer it's there, the more likely it might be that that's created. So I think it fits that kind of overall face and content validity of the argument. I think from a methodologic standpoint, there are some real questions about whether these data are showing what we think they're showing, but since it meets the kind of eyeball test and I think reflects most people's practice, I think most people believe the results. I believe the results that, a suture that dissolves is less likely to create a problem over time than a suture that doesn't dissolve. I guess kind of the takeaways from the article for me, from a practical clinical standpoint, I have never done, personally, I haven't been doing this for very long, but I have never done a ventral mesh rectopexy with permanent suture. So I've done them with Vicryl, a shorter absorbing suture, and I've done them with PDS, a longer absorbing suture on the rectum. We use permanent suture on the ligament is how I was trained. And so it's not as meaningful a comparison to me, but I'd be interested if other people are using permanent suture on the rectum. I've always had that concern, and therefore I've never really done it that way. But I think Charlotte kind of framed at the end the major point, whereas life is about trade-offs here. So it would be really interesting to know what we're giving up by having a dissolving suture over time. So because this is kind of a mixed cohort, they don't even say, is it internal, external prolapse? We don't know, is it all people having this procedure done? We don't have any measure of outcomes at all for these patients other than whether they had a mesh erosion. It's hard to know if we're giving anything up by going for a safer approach with this dissolvable suture. If the answer is no, then the answer is clear. We should be using a dissolvable suture to avoid this rare but potentially problematic complication of the procedure. If, as is the case with most things, there's a trade-off there, we should at least understand what that trade-off is in making the decision of which suture to use. So I think overall it fits what I would have expected to find from the study. And so for that reason, I think that it's a contribution, but I'm not sure that it affects my practice much, again, because I've always been using PDS for my sutures.
A very useful point. A couple of the questions that I have for the host institution and anyone else, I guess, as I understand that they're kind of talking about a cutting seat on type of situation where the permanent suture would eat through over time. And my question is, does anyone ever check if the rectal sutures are full thickness? And if they are full thickness, would you take them out?
Yeah, I check, and I would take them out.
Okay.
Yeah, and then I would leave the mesh, but I would have more prayer.
Fair enough.
Maybe an irrigation. Yeah.
The other thing about the sutures specifically, I granted that one suture is permanent and one is a dissolvable, but they're not comparing monofilament versus polyfilament. And so I don't know whether Ethibond would be a better comparison with Vicryl, and say nylon or Prolene would be a better comparison with PDS. But I guess the question for you guys is, what do you do? How do you place the sutures? Is there a role to place glue or something, particularly if the sutures are full thickness and are removed? Yeah, so please elaborate on your technique.
So I use PDS, okay, with the idea that it lasts a little bit longer than Vicryl. I do not, so the Europeans are using glue in a lot of the videos to stick it, to use it for the glue substance, but I don't really use it for there. I will sometimes use a fibrin glue if there's any raw surfaces, and so that I can avoid a post-op hematoma. So if there's any kind of if it's the least bit wet, like something that I would accept when you're doing more of a rectal, like a rectal cancer operation, I'm less likely to accept with the mesh. And I'm very happy to say, oh, let me have the fibrin glue, and I'm going to stick it a little bit. I'm going to stick it and use it for the glue purposes. So like I double duty it. And the only interesting thing I've started to do lately, because I've been looking at other people's videos, including my own, is I was using a certain number of knots. And then somebody said to me, why are you using PDS? I always taught that PDS is 6 knots. And they're like, why do you use so many knots? I've never had a problem with my knots. But once someone said to me, why are you using so many knots? I said, if I get rid of some of the knots, I can cut off my operative time. So I've been decreasing the number of knots and everything seems fine. So like learning from someone else who commented on my specific video.
It's really a shame Dr. Lavery never did this operation, because he didn't do it more than 2 knots for anything. That's interesting. I remember maybe last year or the year before, you did a session for ASCARS about robotic ventripexy, and there was quite a bit of discussion about the tension of the mesh and how to ensure that it's not too pulled up. And I guess when there's an erosion, that leads me to wonder whether there's either tension in the stitches, particularly is it extracorporeal versus intracorporeal, and does it matter? Clearly for robotic, you wouldn't do extracorporeal, but these guys did it laparoscopically. But also, if you can just elaborate on how do you ensure that it's appropriately reduced and not overly reduced?
So yeah, great point. So I would say, first of all, I always measure when the patient is asleep, and I'm looking for what I call the lead point of the prolapse. What's the most proximal aspect of the prolapse? Because I want to include that in the repair. So that is my thought process. Like, I don't want, like, I may go all the way down to the pelvic floor, get to the perineal body, but if the prolapse starts up higher and I don't incorporate it, I think that the recurrence rate will be higher. So I keep that in mind. And then, yes, you know, we initially tensioned things pretty tight, and there were some problems with, you know, mesh erosions and issues. And so I wanted to just kind of sit in that concavity, like in the sacral concavity. I don't want it to be overly tensioned. With that said, I do go below and I feel and I see if my prolapse is reduced, and I make sure. And if I felt like it wasn't for whatever reason, then I might retension the mesh a little bit. You know, so again, we don't really know. Like, I don't know what the magical, I can't give anybody the formula, but I kind of feel it on a case by case.
Thanks very much. I don't have any more questions about this paper. I note from the chat there was a question about you doing MR defecography and whether that's physiological. I still have in my mind Dr. Hull's strict instructions that everyone should get a defecating proctogram. And in fact, when I tell the patients, this little voice in my head actually reminds me to tell them that it's embarrassing and uncomfortable and cold. So all the patients get told that. But yeah, so why MR defecography, and what information does it give?
Yeah, so I'm not actually, so in this specific, for the patients who have known rectal prolapse, I'm not really using the MR defecography to identify their extent of prolapse. I'm sending them, and I know they have rectal prolapse. I'm really looking to see the coordination of the rest of the pelvic floor, what their levators look like, and other features of multi-compartment prolapse. And I'm also interested in cul-de-sac hernias. I don't have the data yet to say how that makes a big difference, but one day I will. And so then when, you know, I gave you a couple of slides to talk about, you know, a pelvic floor center. We actually once a month sit as a big group, we discuss cases, and we go through each of the MR defecographies. And within that, we have taught the radiologist what we see clinically. Sometimes when a new radiologist comes on, I know that I actually bring that back up to them because I can read the MR defecographies better than they can. And I now know what I'm looking for. So I agree. It is not as good as an upright if I'm specifically looking for the posterior compartment. But in this case, I'm looking to see the interaction, and the MR defecography can give me excellent images and an overall, you know, a lot of information around the whole base of the pelvic floor and what the rest of the muscles look like.
Thank you. I guess we should go to the next component, which is the results of our poll. And Stephen's got those ready, I think.
Yeah, is that sharing? Should be coming up. So the poll, which was asking about which patient factors are important in deciding on index operation. So age, fitness without a huge attribution to sex seems to be the winner, following shortly behind by people that do take into account the patient sex. And then less so the equipment. There was, you had mentioned, we wanted to bring back up the poll or the chat question. Dr. Mackerel asked about BMI as a significant contribution to his decision making.
Yeah, I think the BMI point is quite interesting. Dr. Gerland, what do you think? Does that play into your decision making at all?
So I'd very much like everyone to be optimized before they have a quality of life prolapse procedure. So if I am their motivator that they have to lose weight, then so be it. Right. So like they frequently have to come back or work with a weight loss specialist or do whatever those things are. So BMI isn't affecting which operation I give them. It's, am I giving them an operation at all? And what can they do to put them, you know, to make them the best quality patient where this repair will last?
Do you have a number? And does it differ between male and female given the disparity in where the fat is?
I don't have a number. I don't have a number. I know that robotic surgery works very well for BMI, and I'm a lot like, I think some of the Cleveland Clinic stuff was, we ended up doing a lot more robotics with higher BMIs. So it works great for that. But I'm talking physiologically from an optimization perspective. You know, I'm a big believer in diet and exercise and getting down to a more optimal weight, but I don't have a number. I don't think it's for me to decide yet.
Dr.
Okay,
Mackerel
thank
did
you.
comment again. Sorry, that specifically the Dr. Mackerel that brought this up uses 35 as a BMI cutoff for lap ventral rectopexy.
Thank you. Thanks, Stephen. Let's now move on to the next section, which is the special guest segment. And so I guess it's fortuitous to have the person who helped organize it is being the special guest herself. So Dr. Gerland obviously has a huge list of achievements, far too many for one slide. That's why she's got multiple slides. But I think one of the things that really stands out for me is her incredible energy, which is both unparalleled and infectious. And I remember when I had an opportunity of being her trainee for a short period of time, she never sits still, which is actually even physically hard to keep track of, but also she's always motivated both clinically, but she finds time, or at least found time with me, to talk about life and give some life advice, which was very helpful, but also kind of in general differentiate some mentors from others. With this being said, let's start the chat about what is the Pelvic Health Center and how did that come about?
Great. So I really would prefer this being like a conversation. But I did put some slides just so, because you asked me a couple of questions. Yep. So like the first one of the things that you asked me was that this isn't a unique idea. Like this model, it exists in the UK. Like the US just takes a lot longer for things to come, to fruition. There's definitely the interdisciplinary model for oncology. There's the tumor board. And of course, for those of us who work in here, of course, this makes sense. The pelvic floor is one unit. We should be doing it. But really what it comes about is how. Like, how do we do it? How do we, in our current structure in the US and the financial constraints, how does that work? And yes, it should be for IBD too. I agree. So we should pull everyone in. All right, go ahead to the next slide. Okay, so you can just keep flipping. So just a little bit about our model that really wasn't necessarily my design. Like I was at the Cleveland Clinic and then I was invited to Stanford because they had decided to set this up. And I came in as the medical director of it. They had a unified location. So for the first year, we were all separated. We all met and everybody shared Epic, which is our electronic medical record. And we went back and forth on patients. And then it took about a year before the space was completed, and they already had a design in mind. I didn't have a lot to do with that, but we were located in one location. And the key point is that there's a physician champion from each specialty. Like this doesn't just happen. You have to have people who are interested in taking care of the patients and in this being their focus. You can't really, like, if you want to do pelvic floor the right way, it can't be a side gig. You sort of have to love it, or learn to love it. And then the other thing that I can't stress enough, and I'm pretty sure that saying, you know, I'm preaching to the choir, but I'm saying it for the administrators and for when you go back to your center and you go to talk, that we take care of patients, but it's the glue in the middle. It's the advanced practice providers, it's the schedulers, it's the nursing, it's the coordination of care piece. And that has to be, and I would say when I got there, I had to explain to them, it's great how many doctors you have. It's great that you have surgeons, but if we don't have the glue that's gonna kind of see the patients through the system, this will never work. I think I have one more, and my key, like what I learned very early is great. I do a couple of surgeries, but who are the most important people are going to be my pelvic floor physical therapists, and who are going to be in the greatest demand, and who, like, it's certainly that, for pelvic floor, you see a lot of patients to do a surgery. For a pelvic floor physical therapist, they are already booked out and we have to keep stopping their practice, and I've got to hire a new one. So as someone who is building a program, this becomes one of your key components. And we don't have a lot of data to back it up, but as in, should all patients who have rectal prolapse have pelvic floor PT before? Should they have PT afterwards? Should they, we don't have that data yet, but I can just tell you from anecdotal and from my own patient experience, it's a humongous help to have very engaged and wonderful physical therapists. And I also say from Cleveland Clinic, I had the same experience. All right, wait, now I feel like I'm lecturing, and maybe you should you can go ahead with the slides a little bit, because you can see,
So sort of just zooming in a little bit, is one question is, specifically what disciplines do you need as a minimum for this to work effectively?
So at a minimum, if you're dealing with a lot of prolapse, you want to have someone who does posterior compartment, and you want to have someone who does anterior compartment, right? Like, you have to have those specialists who know how to do that. You need to have someone interested in radiology if you're going to use imaging. And so again, there's this whole question, where's the role, how important it is, but I think moving forward, for us to learn more about prolapse patients, we're really going to need to know more about their tissue quality and about the interaction. And then one of the things that I really think is fantastic and where I've learned a lot is with working with Dr. Nishadian, who's on the call also, and this is pretty unique. It's the, how do you share, shared custody of patients when they also have functional bowel issues and they have prolapse, and where does that, where is that interaction? How do we engage everyone to take care of patients?
And what are because it sounds like these patients sort of find their way to the pelvic health center from different kind of presenters. What are the common presenting complaints? Is it incontinence? Is it prolapse? Is it pelvic pain? What is the list of things you do? And specifically, say with incontinence, like you've mentioned frailty before. So do you need a geriatrician more so than, someone that can offer a divine intervention?
Yeah, great point. So I would say all of those things, right? They come in with symptoms, they come in with anatomic findings. We marketed towards prolapse and not pain, because prolapse brings in revenue, whereas pain takes a lot of time and doesn't have the same thing. We engaged a geriatrician, but that really didn't work out. So we have we had some initial conversations, but we send them, the frailest have to go back to their medical doctor. And the other key one is a psychologist, right? That's the holy grail, really discussing the underlying. So we have someone who's working with us now, and we're protecting her. We're not letting everyone see her. We don't want to overwhelm her. We want her to be happy, so it's that interaction between people. So, so we're kind of, I guess we're saving the worst of the worst for her. But, who is the group that, who she will see, who might have prolapse and other underlying psychological issues.
Thank you. If that's okay with you, you've advertised the wonderful gastroenterologist that you have. I was hoping to ask her a question. if she's on the call. And my question really is the balance between functional colonic inertia and the association with some of the maybe mechanical problems that we see as colorectal surgeons. How do you approach this, and what is your sort of view and workup?
Sure, thank you for having me. And from the GI perspective, in the world of the motility and neurogastroenterology, we really see the structural pathologies secondary to functional or basically motility problems. And we often think of a functional problem like pelvic floor dyssynergia, which has led into years of straining, and this has led to the anatomical problems like the prolapse as the result of unaddressed pelvic floor dyssynergia. And we know that in many patients who have dyssynergic defecation, pelvic floor obstruction because of the functional pathologies, secondary motility problems like colonic motility dysfunction can happen. And by addressing the pelvic floor dyssynergia in these patients, we can achieve normal motility in the colon, at least in a fraction of these patients. So for us, really the focus is addressing the functional rectal pathologies. And really, as you heard, the pelvic floor physical therapy and biofeedback has been the mainstay of our therapy. And surgery is definitely very helpful for patients who have advanced stages of rectal prolapse, but definitely this is not really indicated for many of our patients with low grade of the internal rectal intussusception, or if the patients have, let's say, concomitant pathologies like irritable bowel syndrome. We know that if we don't address these problems, the outcome of the surgery is going to be dependent on these as well. And this is likely to impact the outcome of even the best surgery negatively.
Thank you. That's wonderful. My next question is, having a pelvic health center and now just seeing the diversity of opinions and management, do you think in general this leads to greater or lesser surgical intervention?
I would say that in our practice, which is a big academic center, and we definitely have the high number of tertiary referral cases, this probably ends in having the surgery reserved for the right patients who are definitely a good surgical candidate. This doesn't mean that we are not offering surgery to the patients who need that, but it's definitely very carefully selecting our patients and avoiding the unnecessary surgery for patients who have other pathologies that are the main drivers of their symptoms and definitely are not good candidates for surgery. And this is, I guess, like the whole concept of the multidisciplinary clinics, integrated care for patients who are complex. They are the ones who benefit from such care, and having multiple disciplines, being able to really address their problems. This is how we can take care of these patients to benefit them and really improve their overall quality of life without providing or offering unnecessary surgery or interventions that will not really be helpful to them.
Thank you. Brooke, one of the things that I remember with you is you had quite a few trainees from different disciplines. And so what is the training benefit of pelvic floor, sort of the pelvic floor center, pelvic health center, and who do you have that sort of benefits from it from a next generation of surgeons point of view?
So there's a FPMRS has a fellowship. So they rotate with us. I have many surgical residents who are working with us. We have a slew of trainees that are coming at any time. And then we also have some nurse trainees and things like that. So, and then I've had GI, so I will frequently have GI fellows come with us. Am I missing anything, Layla? I don't think so. Yeah.
Thank you. One thing I did at fellowship, which I highly recommend to other trainees if anyone's listening, I took a day to just follow a pelvic floor physiotherapist. And I think I've learned more in that one day than I did in a whole week of, ventral rectopexy, suturing. I thought that was an incredible, insightful opportunity. And I take your point about how useful they are in a pelvic floor center. You mentioned when we emailed before that you have a shared leadership in the pelvic health center. Can you elaborate on that, and generally your view on the benefits or cons of having, rotating leadership versus one sort of authoritarian type setup?
Yeah, so it comes down to everybody has to have a piece of this and buy-in. And so we rotate it right now. The urologist has taken on the leadership position, and we have grown from a research perspective. So I've taken on the director of research, and then and Dr. Nishadian's director of motility. So we, in each of those areas we've grown, and then that will rotate in another 2.5 years, I think. I forgot what the number is. So it comes down to really get a group together. Everybody has to have buy-in, and they have to be invested.
I see. Now, I guess this is something that interests me, and I'm sure I'm not the only one, but it's challenging to introduce something like that, not only as a concept, but actually, mechanically. And so what are some of the objective markers of success that people can take to their local hospitals when they're trying to sell this idea?
On some of the slides, I talked a little bit about how we did the revenue, because that is really the question that comes from everyone. You can't get around it. It's my least favorite conversation where I talked about, how many people were referred, how many surgical cases, how many were combined. For us, this was just our first 100 patients so that we could show what that looked like. And then, so the way that we work it is that, and it's the first slide where we talk about the flow of patients through, where the technical and procedure fees go back to, sorry, you can go forward now, you're too far, but the technical, go back to the middle slide. The technical fees go back to the individual, groups. So, and then any of the, you could stop for a second, any of the procedures that are done in the center, then go into the center. So it really comes down to what makes sense for your group, and the APP, or the nurse practitioner role, or PA, is really covers all of us. And now we've gone to 2. So we keep growing. I keep filling their slots, and again, that'll be different on each group. And it just depends on us supporting each other. This, I think, is our one of our biggest accomplishments, is this monthly conference, because there's a value in it for all of us. It's people who may not know the patient come in and give their opinion, and what should we do, and we really look at things in a new way. And I've learned so much from each of the different specialties, and it's been part of really kind of making this MRI work, which I agree, we were all trained fluoroscopic defecography, but this is incredibly helpful. So yeah, the revenue is really, we also use it as a working conference. We make decisions, it gets documented in the charts, and then we decide who's going to communicate with the patient. Because really, a lot of times we choose the most difficult patients who were saying I don't know what to tell them. They're talking to each of us differently. How do we do it? Okay, you're going to be the one go-to. instead of that kind of siloed effect of care where they bounce around. So and sometimes, somebody asked in the beginning, what happens, I only have, I don't have a full hour to talk to the patient. How do I minimize that time down? So sometimes I'll say, all right, tell me your story, I let them do their spiel. And then I say, this is what we're focusing on. And I'm going to bring this to our combined conference and we will discuss your case. These are the other doctors that you need to see. And then we communicate either via virtual visit or sometimes there's a letter, but one of us then communicates back to the patient.
Thank you. That's very helpful. My last question is, what do you think is the minimal amount of patients you need for this to be sustained? And granted, you are clearly growing and it's a successful venture, but for people when they're starting, I think that's one of the concerns because you want to fill the clinics, you want to fill the MDT. What do you think about that?
So then I would come up with this: build it and they will come. You know what that's from? That's from Field of Dreams. Do you guys remember that? So that was, I don't need to know a bare minimum. Like what that doesn't help. If you create quality and you take care of patients, that's the only place they're going to want to go because nobody else wants these patients. So like, for example, if, John or Aaron see someone and they've made an effort and they can't go anywhere else, they're sending it to our pelvic floor center and they're my own partners. You know what I mean? So like the person down the block, they don't want it. So build it and they will come.
Okay, well, thank you very much. I personally have had a wonderful hour. It's been very useful. I hope other people find it as useful as me. Thank you all for your time. Thanks to the authors for joining in, and obviously for the wonderful host institution. We are having a month off because of ASCARS, which is fantastic in itself. And so we'll be back in the end of May. I think in Advent Health would be our next session. So thanks again, everyone, and have a good evening.
Thank you.
Thank you. Bye-bye.